Okay, welcome to the Deuk Spine Institute live stream, and our patient is a very special patient. She travels to us from North Carolina with her husband. She's having thoracic spine pain, and she has an MRI that shows two herniated discs, one at T5-T6, the other one at T7-T8. We're going to be fixing both of them, and her pain is deep thoracic. She's searched far and wide for a doctor who can help her. And she found Deuk Spine Institute and learned that we perform endoscopic surgery on the thoracic herniated disc. So we're going to get started. I'm going to be talking to my team. Thoracic spine is the most difficult of all to treat, and it requires a lot of attention to detail. So the first thing I'm going to do, just to guide you through, is I'm going to place two access needles that are going to guide me for the rest of the surgery. One is going to go into T5-6 and the other one into T7-T8. To do that, I need to use the X-ray machine to identify the proper discs and also to navigate. So for localization and navigation. So that'll be the first part of the surgery. My patient's then going to help me with a discogram, and then we're going to put her to sleep where she can rest comfortably while we fix those two discs. We're going to finish the surgery off with Deuk plasma rhizotomy, L4-5, L5-S1. Are you comfortable? We're going to get started, okay? All right. So I need to make sure I'm at the right levels, and to do that, we need to start with what's called localization. So let's count from bottom up. Let's start at T12. Where is my monitor? I guess that's it. All right. So right now I'm at, let's see, 12. Let's see, that's 12 is the last rib. 11, 10. So I would be at T10. You all agree? Yes. 12, 11, 10. Interesting. And we need to make our way up to 7, 8. Nine, 8. Go ahead. That should be 8 right there. So 12, 11, 10, 9, 8. We're doing 7, 8. So we're doing this disc right there, right above that. Let's see. Maybe you can bring the base a little bit closer so I could see a little bit better.
Yes, sir.
A little bit, no, that's good, but a little bit to you. Yep, perfect, that's good, that's good. All right, so our first disc is right there, 7, 8. And I want to count once again, but this time from the top down. So let's move to the top. I should be at 8. Let's move to the top and let's find the first rib. All right, so there's the first rib. We need to clean that up a little bit. I can see the first rib, and that looks like T1. We need to change the angle of the fluoro a little bit, probably angle it top forward. Yep. That's a little bit better. All right, let's just say that's T1, 2, 3, 4, 5, 6, 7. So let's see. T1, 2, 3, 4, 5, 6. We're right at 7. Should be 7, 8. Let's see if we can clear up our counting a little bit better. All right. Huh?
I was going to say I angled a little bit more, but it didn't change anything.
Well, I want to see the first rib, so I need you to zoom in a little bit more. I mean, if that's first rib, it's hard to tell if that's first rib. Let's go a little bit more north. Shot. Where do you think the first rib is? You think that's it? All right, so if that's T1 then, go to the T1 pedicle. Yeah, that would be the T1 pedicle just to the right of that. Then that would be 2 below, 3, 4, 5, 6, 7, 8. All right, let's see if we can visualize that first rib a little bit better. Just to be 100%. Did you guys see the counting there?
Yes, we did.
So counting is very difficult in the thoracic spine. And we're counting from top down and bottom up. We're doing it both ways. You're really supposed to count obviously either top down or bottom up, but I like to do both. That way you can confirm. No, you got to take a better picture. You're going to have to go further north if you can, but I want to clearly see T1 rib. See, I'm not seeing a clear T1 rib. Can you bring the fluoro a little bit to you? And shot. I don't mind if I see the rib on either side. What is that right there? Is that the ET tube? No, what is that structure there? Not that. The big tube-like thing, that.
Oh, that's.
No, it's not an ET tube.
These were at a
Oh, okay, get that out of the way, please. That's confusing everything. Let's take a look again. Shot. Okay, so there's the first rib right there. You see it? It's easier to see on that side. Uh-huh. Then the second rib is T2. You agree? If that's 2, then let's keep counting down. Well, just move the fluoro a little bit down. So really we're seeing the first rib on the left side better. Strange, isn't it? She has a weird rib on the right side. I'm not really seeing a very good rib. But, all right, so let's count down on the left side. So that's 1, 2, 3, 4, 5, 6, 7, 8. So if we count down from the neck, we're at 7, 8. And if we count up from the bottom, we're at 7, 8.
correct.
So both ways we're coming up with 7, 8. All right. Well, I like that. So let's come back to where I am. And let's use the bottom ribs 12 for the rest of the surgery to help us, because I think it's going to make it a little easier with the fluoro. Uh-huh. That's good. That's good. Let's get a shot. All right. So we can see 12, 11, 10, 9, 8, 7. I'm right at 7, 8. All right. I'm happy with that. So do we do numb them? Let's give a little more numbing medicine. You're going to feel a little stick and burn. Sorry about that.
A little more going in.
That's just to help make you more comfortable.
Burns a little bit.
Shot. Okay. Shot. All right, so let's go with, need to go a little further south. Where do you feel that? Huh? Let's go with a lateral view.
Where you feel that? Where you feel that in your upper back?
All right, I'll give you some numbing medicine. Let's give her some numbing medicine. Let me get a lateral shot. No, let me do it. Yeah. Just giving you a little numbing medicine, that's all. Mm-hmm. You doing all right? All right, let's see if we can't get a little bit better picture of that disc. So you're going to have to center the fluoro higher, go up more north. Cut out some of the stuff in the back that's giving us overexposure. Darken up where we are. Shot. That's better. All right, so you can see the disc space. You can see the facet. It's a little bit overexposed. but I can actually feel the facet, which is what I want to feel. And I want to work my way around it. Sean? Yeah. Now we're around the facet. You doing all right? Give me an AP. I can't hear her. You've got to tell me what she's saying.
She said she's still fine.
Good. Everything's going well right now for you. Henry, do you have a good view of the MRI?
Yes, we do.
Oh, it looks really good right there. That looks really good on the AP. All right, so we can even count the ribs. So 12, 11, 10, 9, 8, 7, 7, 8. We're at 7, 8. Let's bring the fluoro slightly south, just a fraction of an inch. That's it. And just so we can 100%, yep, there it is. So you can see there's no rib at L1. Show us L1. No rib at L1. Then you got 12. Show us the pedicle of 12, the rib at 12 pedicle, and then 11 pedicle, 10, 9, 8, 7. There's 7, 8 right there. So we are exactly at the 7, 8 disc as we've counted properly, and things are going quite well. We're almost inside that disc. You're doing great. Are you comfortable? I need you to echo what she says. All righty. She said yes. Where do you feel that? Where do you feel that?
Right at the spot.
Yeah, don't move, okay? Sean? So it's lined up perfectly. You can see I've changed the angle of my needle to head downwards, but this is really quite perfect. Sorry, it's a bit uncomfortable. But guess what? We're in our first bad disc. Great news, success. Okay? Now, since you're awake and helping me here, would you say you could feel that spot pretty well, right? You can feel that it comes from that area in your back where you're hurting, right?
Where is it? Where are you feeling it?
Are you understanding me?
Yeah. Where are you feeling it?
All right, that's good. We're fine. I'm going to give her some more numbing medicine. We're going to, so that was, everyone agree that's 7, 8. I think that's 7, 8 based on my counting from up, down, and down, up. The next one is 5, 6. So we're going to skip a disc, right? And we're going to do 5, 6. I'm going to give you a little more numbing medicine, okay? Don't be upset. That's just the numbing medicine going in. Well, oh no. All right, so Jordan, no. Jordan, can you get us on the 5, 6 disc better? So I need to see down the axis of the disc. What is that thing there? That's the scapula? That's just the scapula in the way. All right, I think you're off on orbit, and I think you're off on wag. So let's try to orbit and wag it. What we're doing, folks, as you're watching, is we are getting the disc lined up properly with the fluoro. And here's why. The fluoro is what guides us. If the fluoro information is wrong, we will never get to the disc. I think you're off on orbit, but you definitely got a good wag. Your wag was much better. You're not far off on orbit either, I don't think. Hey, that's pretty darn good right there, Jordan. Yeah, that's really good. All right, show us the 7, 8 disc. Okay? And that's the one with the needle. Show us the one above is not 7, 8, but it's 6, 7, and then the one above is 5, 6. So now that Jordan has got the disc lined up beautifully, we're looking down through the disc from the side to side. That's the view we want. All I need is to see the back a little bit better. So I need Jordan to, there we go. There we go. Beautiful. All right. So we're going to come in from the back. And he's playing with the windowing. No, that's too much, Jordan. I don't know what you're doing. You're getting a little heavy-handed there. Shot. All right. There we go. I think that's fine, Jordan. I'm happy with that. I can live with that. That looks pretty good. So what we've done, and I think we're off on orbit actually, a little bit off on orbit, just based on the C6 vertebral body. That might be better. Try a little more. The reason why, and this is the most challenging part of the surgery, is this, I don't know, what do you think? I think it looks better, right? What do you think? I think it looks better, right? Yeah. So what we're doing, folks, is we have to have reliable navigational information. And since we're using this X-ray machine to navigate to the area we need to be in, we must make sure it's reliable. So we need to line everything up so that all the angles are proper in order to do that. And that's what we've spent our time doing, is lining up the X-ray so that we have reliable navigational data from the spine itself and through the machine. It's very important. Thoracic spine is no man's, no woman's land. I'm not trying to be sexist in any way, but a lot of doctors won't go there because, frankly, it's very hard to treat. That's just my elbow on you, okay? Don't be upset. I was just resting my elbow. Sean? All right, now we need to make it up to that disc. I need to be a little bit further up. That's okay. Yeah, you should always drape wide. Give me some more num-num. We're going to put a little more numbing medicine. Blood pressure's good. No epi, right? We're going to give you a little more numbing medicine, all right? Any questions from our audience?
Yes, we have a question from Exy on YouTube.
Yep.
And they ask, are questions about the surgery live, answered live?
Yes, they are. See? Hi. What's her name?
Exy.
How do you spell it?
E-X-C-I-E.
E-X-C-I-E. Exy. One of our viewers' name is Exy, and yes, we are answering your questions live. All right. So, we're literally at the top of our incision, and this is where the other disc is that we agreed to treat. Shot? Shot? You're doing great, by the way. Hang in there, okay? Huh? Yeah, we're almost done with the hard part, with you being awake. Shot? I could feel the facet, and I want to go just lateral to the facet. Yeah, I know. I apologize. That's uncomfortable. All right. Can you show us the facet, Jordan? I can see it, but I want the audience to see it. That is correct. And you see where the needle is, just lateral. Shot? All right. So I'm trying to sneak around. I'm encountering some bone. AP, we're going to use another view. Just to see where we are. So we're a little bit, well, actually we're in really good position. We're in between the rib heads, just at the top of one of the rib heads. I may have to change my entry point slightly, but you can see we're heading towards the back of that disc. Shot? This is not a bad trajectory if I can make it work. You doing all right? Shot? All right, so I am probably going to need to be a little bit higher than I am. Shot? Shot? All right. What is it? I can't understand.
She wants to know if you're a guide wire or anything.
No, we don't want to have a conversation about what we're doing, okay? I just need you to give me certain feedback. You'll be able to watch your surgery later. We're not going to talk you through step by step with you being awake. I need to focus right now on what I'm doing. All right. I need you to relax and give me some feedback if you're having a lot of pain in anywhere. Just tell me, okay? All right, so let's get another AP. So far, everything's going well. I'm just encountering some of her, probably her facet joint. And it could be a little bit more medial based on that image. So I'm going to try to get a little bit more medial. And maybe encountering the TP. All right. Yeah. Oh, interesting. Shot? You okay? You're doing great. Shot? I'm just having a hard time getting around the facet. See how the facet may be a little bit off? I wonder if we can adjust the orbit, because there seems to be some rotation between 5 and 6. Yeah. Try the other direction. Try, I don't know, try a little bit more. It's hard for me to say. What do you think? No, I agree with you. It is difficult. All right, you want to show me what you've got, Jordan? Once again, we're adjusting the x-ray, the position of the fluoro relative to the spine. I mean, those are the posterior elements. If you look at 6 lines up nicely. It's just 5 that's a little bit difficult to see. But 6 pedicles are good. 6 off on orbit a little bit. Can you reorbit 6? Maybe play with the orbit again. Let's just look at 6. If we can get 6 good, then maybe 5 will come into view. That's a little bit better. Huh? Uh-huh. Yeah. Actually, that to me looks a little better with respect to the back of the vertebral body. I don't know, maybe try a little more. Maybe we're going too far. Shot. All right, well, whatever you did, the back of 6 to me looks, I don't know if it's worse. I think it might be better. Let's try. In a way, it looks worse, but let's try a little more and see what happens. Shot. What we're looking for is changes. Definitely worse at 7. So let's go back the other way. I think it is getting worse. The reason why the fluoro has to move around in an arc is some people have scoliosis. More? I think that's better, to be honest. I think you're getting in the better in the right direction here. Are you awake? Do you get pain up here? Huh? Occasionally.
Is most of your pain down at the lower one or the upper one? There's two
areas we're working on.
Yeah.
We'll tap on it for you. You tell us which one. Tap on it
Yeah. Do you get much pain up here?
occasionally, okay?
Most of it's here, right?
Yes.
So it's the bottom one that's the worst one. Well, I'm not going to take too much chances here. I'm going to keep trying. Are you okay? I'm going to keep trying a little bit more to get in here. But at some point, I mean, I'm just feeling solid bone. You know what I could do? Shot? Could just pull the skin up a little bit and see what we can do there. Shot? All right, that seems to be better. Shot? Remember, when I say shot, what I'm really doing is getting a picture. It's a X-ray image. And there's something just obstructing my path here. Yeah, you do. There's no doubt. That's what I'm dealing with. What I'm trying to figure out is, you know, is it worth the risk to, if you don't have much pain up here, maybe we don't take the significant risk that it takes to get down to that disc, because I'm encountering a lot of bone. I cannot find a way around it at the top one, which is the one that doesn't bother you that much. Let's get an AP.
What do you say?
I'm just thinking out loud for you. See that? There's some kind of a growth there. Yeah, that whole thing. It's something very unusual. I mean, let's go back, yeah. But you don't see it at the other levels, it's just there. Let's go down, back to a lateral view. There's some kind of weird structure there. I wonder if some kind of weird facet joint. Some kind of like abnormal facet. You know? And I just cannot get around it. It's just not letting me through. Shot? Well, this is not really where she's having most of her pain. All right. Are you comfy? Yes, sir. All right, we're going to put you to sleep in just a minute, okay?
Yep.
All right.
Getting there.
Any pain right now?
Any pain? Say it again? I'm sorry, I couldn't hear you.
You either have pain right now or you don't.
Yes. You have pain? Yes. Where is it located? Up high by the needle?
Okay, all right. All right, is that your typical pain? Yes, sir. How high is that on a scale of 1 to 10? 8. What's the highest it went?
10.
10, and that's where you typically get pain. All right. So, based on her MRI, she's got a herniation here and here, which the bottom herniation at 7-8 lines up. You can put her to sleep. Lines up with her herniation at 7-8. She's got 10 out of 10 pain there. Now, when we were trying to get into the higher disc at 5-6, I hit this weird bone growth off to the right side, and she's saying she doesn't have a lot of pain up here. Her pain is here and even here, but this is not a disc that we're treating. So we're going to have to go back and look at the MRI again, because she may have another disc that is causing pain that we didn't pick up on the MRI. But definitely this one is causing 10 out of 10 pain, and hopefully this is going to fix that problem for her. So that's what we're expecting. I need you to count out loud from 1 to 100 for me. When you wake up, we'll be done with your surgery. Keep counting. You might feel a little burning in your arm. That's just the medicine going in. All right, so T7-T8 is 10 out of 10 concordant. Did we document that? And T5-T6 inaccessible. But I don't think there's pain up there, so. Are you awake? We've put her to sleep now. We're going to make our incision. It'll be a 4 millimeter incision. This is a stab incision we call for endoscopic surgery. Right along where the tube is going to go down along the guide wire. And you can see from the lateral x-ray shot, she has the guide wire in the disc where the discogram was done. You can see the dark dye in the disc. So we're going to use a dilator to slide down the guide wire. Shot. You're going to watch on a lateral view as this dilator slides down the guide wire right to where the back of the herniation is. Shot. You guys see that? Shot. All right. I'm actually feeling that we're at the back of the disc right now. Shot. Okay, good. Now let's get an AP. We're going to just verify on the AP view. Just for those of you wondering, her midline, the middle of her back is right here. Move your hand, please. It's right here. Keep going. So we're just off to the side of the midline. Beautiful. You guys see that? The tip of the dilator, brighten that up a little bit. The tip of the dilator on the x-ray is right at the mid-pedicular line, which means we're right at the disc, the back end of the disc. So I'm going to advance this dilator into the disc through the annular tear that's already there. I'll use my hands to gently force it forward. Shot. Once you get it going like it is right now, you can take the guide wire out and you can use the mallet to advance it a little bit more if you need to. And then we're going to bring the tube, the endoscopic tube. And for those of you who are interested, the entire surgery at this disc is going to be done through this tube. Okay? So it's 4 millimeters wide, which is why the incision is only 4 millimeters. You don't need the incision to be any bigger than the retractor or the instrument used to create the channel to do the surgery. She doing all right? Shot. Okay. Bringing the tube down. Shot. Passing the facet. All right, I can feel the tube at the back of the disc. Shot. And you can see that there's been a little bit of movement of the patient, so she's off on orbit. Literally, the tube is in the back of one side, which is further back than the other. Shot. All right, yeah. So Jordan corrected it a little bit. And now we're entering inside the disc. Shot. We're inside the disc now, and we're inside the annular tear of the disc. And that's where her pain is coming from. We've already confirmed that with the discogram that this is the source of her pain. Any questions from our audience?
We have a comment and a question. This comment comes from S. Allred on YouTube, saying, "You are changing the world with this operation. I am surprised the Japanese hasn't reached out to you regarding this technology."
Well, thank you so much. I appreciate it. We try really hard at Deuk Spine to do what's best for the patients in the world that are suffering. And we focus on really the patient experience. And that's our top priority, is doing what's right for people. So the Japanese, I don't know. I mean, I have a lot of respect for all doctors, but the Japanese, the Koreans, the Germans, the ones that pioneer this technology, the endoscopic technology, I admire them. They taught me the basics. You know, I don't know how to answer that because I have a bad feeling that most of these doctors are putting, you know, they're doing fusions because fusions honestly pay a lot better money than endoscopic surgery. And the fusions are promoted and supported by large companies like Medtronic and Deuk, and those companies are promoting fusions and artificial discs all over the world, not just in the United States, but they've got sort of a stranglehold on spine surgery around the world. Thank God there are independent surgeons like me that are not on the payroll for those companies. They're not influenced by them to do bad things for our patients. But there's an awful lot of bad surgeons out there that are doing treatments that don't fix the patient's problem and just you know, make it worse, to be quite honest. So thank you. All right, we're inside the T7-T8. Which disc? T7-T8?
Yes, sir.
Through the right foramen. And you can see the blue stuff, the dye, and I apologize that the view is not better. But you can see that the blue dye has stained to what's called degenerated nucleus pulposus. And for those of you who don't know what that is, the nucleus pulposus is the center of a disc. It's like a hydraulic semi-liquid solid. So it's not a solid like hard, but it's semi-fluid. And when you get a tear in your wall of your disc called the annular tear, which is what I'm cleaning right now with the laser, the blue stuff, the nucleus, comes up into the tear and causes inflammation. And it's the inflammation that's so painful for these patients. It's the inflammation that causes all the pain. So if you can get rid of the source of inflammation in the disc, you can get rid of the disc pain. See the tear right there? The laser is hovering right above it. So the white stuff is the annulus, and it's torn right there. And so I got to go in there and clean that tear so that the annulus can now heal properly and painlessly. That's what's going to happen. When you do this to the disc that's painful, when you clean the tear and you get rid of that blue stuff stuck in there, the nucleus, you basically eliminate the source of inflammation surgically, and that allows the disc to heal naturally. You can see the gold color. It's kind of like an orangey gold when I hit it with the laser. That's calcium. Why would you have little calcium in there? Okay, if you look at that on an x-ray, you won't see it. But over time, it gets more and more and more of it, and you can see what's called a disc osteophyte because so much calcium gets built up that it looks like an osteophyte or a bone spur. Okay? And like I said, most of the time, the bone spurs aren't the problem. It's this inflammation happening in this tear that is the problem. So you can see I'm cleaning that tear with the laser, and it's going very well. How's the patient doing?
Very well.
My anesthesiologist says she's doing quite well. Now, the view of this scope is not as good as you see with the lumbar. And the reason for that is this is what we call a fiber optic scope. And fiber optic means that the image is transmitted from the tip of the scope to the camera by small little fibers, little glass fibers. And the quality of images transmitted via fiber optics is not anywhere near as good as a rod lens type transmission. So the image quality is degraded as a result of that. Now, do they make a rod lens scope smaller? Yes. I don't like it because it's still really big compared to this one. And I just don't like the idea of doing additional trauma, especially in tight spaces like the cervical and thoracic spine. Okay, if you can avoid larger incisions and larger dilations of tissues, you can avoid injuries to all the soft tissues around the scope. And that's what I'm trying to do. All right, great comment. I appreciate it. It means a lot to me. We are trying to pioneer things to make it better for patients so they don't have to live in pain and they don't have to go through horribly barbaric surgeries like fusions that are completely unnecessary and end up resulting in more problems for patients. So this surgery you're seeing now is the solution to back pain and neck pain from a disc problem. That's why it's called the Deuk laser disc repair. So far, everything's going well. By the way, you can see the healthy nucleus down below. We don't talk much about it, but see how white it is? Okay, that nucleus down there is pretty darn healthy. Okay, it looks good to me. I don't think that's scar tissue. I think it's nucleus. And it's the blue stuff that's degenerated. It's the blue stuff we want to get out. Leave the white stuff alone. Okay? All right, any questions?
Yes, we have a question from XC once more on YouTube.
All right, sure.
They asked, on our screen, we see X-ray snapshots. Do you have a live X-ray visual in person that's guiding the needles?
Great question. No, I use the X-ray snapshots that you get. Everything I see, you see. We're seeing the same. I'm showing you everything the surgeon sees. So those X-ray snapshots are what I use. There's no continuous video feed for X-ray. I could do it, but it would be exposing the patient to unnecessary radiation. So we do have a cine mode on this fluoro, which allows us to hold the button down and keep continuously taking pictures, but the amount of radiation released is massive compared to a still shot. So remember, some of my goals during surgery is I want to get the information I need, but I also don't want to overexpose the patient to any unnecessary risk from radiation they don't need, or my staff in the operating room, or myself for that matter. So, you know, taking stills is much better than doing continuous video shots. And the continuous video shots are unnecessary. You just need snapshots to, you know, as waypoints. Think about if you're navigating in a car or boat, you're navigating somewhere. You don't need continuously to think, am I in the right place? Am I in the right place? Constantly, right? You just use waypoints, like a certain corner, a certain building, a landmark, and you know you're in the right spot, and that's what we as surgeons use. So it's pretty common for surgeons just to use snapshots on the X-ray as waypoints to confirm where they're going. And you take those pictures when you're near sensitive structures to make sure you're not in the wrong place. So anyway, surgery is going well. We're removing the herniation quite nicely. There is some scar tissue in here from chronic inflammation. And just for you, for the record, for the 5-6 disc, I wasn't able to get in because of some abnormal bone on the side of the spine. But more importantly, I don't know that the patient's having pain from that disc, because where she mapped her pain out before surgery, it's not consistent with that location. And then when I asked her before we put her to sleep, do you have pain up here? She said, a little, very mild. So what I did was I figured, okay, for me to force the issue and try to get into 5-6, I could end up causing a serious problem for her, like spinal cord injury or pneumothorax, something bad. So I said, okay, is it worth it for me to continue to pursue 5-6 when her pain map clearly shows the pain is lower down, more related to the 7-8 disc rather than the 5-6. And so at that point I realized the risk of me pursuing that 5-6 aggressively could result in a complication, and because of that bone that was there blocking it. So I said, no, this is not worth it for my patient to have a complication. For what benefit, right? Like if that was where a majority of her pain was, I would have found a way to get around possibly, or gone and done something more aggressive. But by being more aggressive, you expose the patient to more risk of complication. So I said it's not worth it. And that's something that you really have to be careful about with a surgeon. You want to make sure your surgeon, whoever you pick, whatever they're doing, that they're the kind of surgeon that puts the patient safety first, you know. And I've had to abort levels in the past when it became a safety issue and I wasn't able to get there safely with my instruments. So anyway, just something worth talking about. Just about done here, and then we're going to move on to the DPR down below. As you can see, the blue stuff, I've gotten rid of most of it. I've cleaned out this tear. Just for reference, folks, so you understand what we're dealing with, that glass fiber there at 12 o'clock is 0.5 millimeters, half a millimeter wide. And that's a bone spur right there, by the way, I'm working on right now. You see that? The laser can blast away bone spurs, no problem. All right, so the laser fiber is 0.5 millimeters, half a millimeter, and the inside of this tube, remember the outside diameter is 4 millimeters, the inside diameter is around 2.5 millimeters. So the inside of that tube you're looking at is only 2.5 millimeters. That's such a small space. If you take your fingers and spread them apart, just barely enough to let a little bit of light through, that's what we're dealing with here. So it's not a big area we're fixing. I know it looks big to you guys because we're under the endoscope, which is magnifying everything, making it look bigger. But the reality is that this is a very small area we're operating on. And the fact is that the back pain comes from a really small area that we're operating on. And that's it. Once you deal with this area right here, once you deal with it, you get rid of the pain. And that's the beauty of it. Just about done. Then we're going to move on to the DPR, Deuk plasma rhizotomy for the lumbar. I think she's going to do fantastic from this.
We have a question.
Sure.
This comes from Chris DaCosta on YouTube.
Sure. Hi, Chris.
They asked, what is the success rate of this procedure? Are there studies showing the efficiency of this procedure?
Yeah, Chris, there are. We published our results for the Deuk laser disc repair for the thoracic. This particular surgery, 99% thoracic pain eliminated. 99%. And that was at 13 months after surgery. So we asked our patients we did this to, hey, so how much of your pain did we get rid of? And they said 99%. That was the average. So it's extremely effective. All right, we're outside the disc. Let me see. Right there. Please don't make loud noises like that. Okay? Do you hear me, Sarah? Yeah. I don't know if you know, but we're working right next to the spinal cord. So I don't need that. So 99% pain gone on average. There's no surgery in the world that gives you 99% of pain gone from a spine issue, except for this surgery. All right, we're done. We're done.
Lights on, please. Thank you.
We're going to irrigate,
Off, please. Thank you.
and then we're going to move on to her rhizotomy for her lower back. She's got lower back pain over the facets at L4-5, L5-S1. So we're going to go in and we're going to deaden the pain nerves. The pain nerves to the facet joints are called the medial branch of the dorsal ramus. And what it is a small nerve branch that comes off your nerve root as it exits the foramen. And it sends a nerve backwards towards the facet joint. And that's the nerve that all the pain management doctors are trying to treat by rhizotomy. They use an RFA rhizotomy. We don't do an RFA rhizotomy. We do a plasma rhizotomy, which is a new technology we developed here. And the plasma is more powerful. The problem with the RFA is it doesn't work. It's not enough energy, and it's directed at one single point next to the spine where the doctor hopes that the pain nerve actually is. But a lot of times the nerve isn't there. And the treatment doesn't work because it doesn't deliver enough energy to that nerve. To deaden a peripheral nerve, you have to cut through what's called the epineurium and perineurium. You have to literally cut through it so that nerve can't grow back. And the problem with RFA, radiofrequency ablation treatments for facet pain, is that the nerves always grow back because the RFA doesn't actually cut through the perineurium and epineurium of the nerve. It just phases the nerve, and the nerve just comes back to life and grows back. So with the plasma rhizotomy we do, we're able to kill the pain from that nerve because we were able to effectively destroy that peripheral pain nerve. And that's what we're about to do. All right, so let's just confirm it's 4551. Everyone agree? 4551, right side. So we're going to start by localizing the facet. And you can see she's got screws in, across the SI joint there. Shot. All right, so the tip of my probe right here, shot, is at the L4 transverse process and pedicle. And the target is literally just in front of where I am right now. So we're going to numb up the skin so she feels no pain while we do this, or as little as possible. And then we're going to proceed. Any questions?
Yes, we have another question from Chris
Sean?
on YouTube. Asking, is this procedure FDA approved and what is it called?
Is this procedure FDA approved and what is it called? Yes, it is FDA approved. We don't do anything at Deuk Spine that is not FDA approved. Shot. All right, we're right where we need to be. And Chris, just so you understand, there's a lot of confusion about FDA approval. The FDA only approves drugs and devices. It doesn't approve procedures. So when you say is something FDA approved, what you're really asking is that procedure using FDA approved drugs and devices? Okay? And the answer is yes. We only use FDA approved drugs and devices here at Deuk Spine. We don't do anything that isn't FDA approved. So the Deuk laser disc repair is FDA approved, and the Deuk plasma rhizotomy is also FDA approved. X-ray. So I'm aiming for that target. Shot. Shot. Jordan, will you show them what I'm aiming for? Pretty much right on it right there. Shot. I seem to be sliding past it. There's the TP. Shot. I'm on the TP. So literally in the perfect spot. Oh, too much contraction. We gave numbing, right?
Yes, sir. And you gotta go in there. She's pretty sleepy.
She's pretty deep.
Yeah.
Well, I don't know that there's anything more I can do. It's more of a involuntary muscle contraction. But anyway, things are going fine. We're almost done with this L4. So yes, everything we do is completely FDA approved. We're done with that one. And even the DPR. Shot. Okay, hitting the superior facet. Shot. Still too high. Shot. Too low. That feels pretty good right there. Let's just see where we are. Shot. How is she ventilating? That's almost 100%. That's the perfect spot right there. Shot. Okay, see where the tip of that needle is, guys? Point to it. Go ahead. That is exactly where you want to be. You see the transverse process? Show them the TP. Yep. That's the transverse process sticking out, and it comes back and attaches to the superior facet right where the pedicle is, the top corner of the pedicle, top outside corner. So right where those meet, that's where we want to be. That's where the bad nerve, the pain nerve lives, and that's our target, the medial branch of the dorsal ramus. The technique you're watching right now will be the technique that all doctors use eventually in the future. They just don't do it now, and I think I know why. Because truthfully, if the patient pain goes away for 3 months, that's perfect, because then they come back and get another procedure, so you make more money on them. We're not interested in people coming back and having more procedures and making more money. We're interested in curing pain. So that's why we do a curative treatment rather than a radio frequency ablation. We don't do the RFA really. We still offer it for patients who want it, but the best treatment for this problem, the curative treatment, is what you're seeing right now, and it's called the Deuk plasma rhizotomy. And it's the treatment, the best treatment available for facet joint pain. Done. We got one more to go. How is she?
Doing great.
All right, so we got 5-1. We got the S1 next. Boy, look how arthritic the L5-S1 facet is. You guys see that? Huge arthritis there. Yeah, show us the target. That's right, right there. A little bit to the left. Right there. That's our target. Okay? If I can get to that spot, then we can have the best possible result. Shot. Too low. Shot. Shot. Getting closer.
We're going to shoot a chest x-ray and auscultate once we can get to the lung fields better. We'll shoot a chest x-ray and auscultate.
Standard. Are you concerned?
Not at all, but you're asking about the lung fields.
Absolutely.
I cannot access them. Right now our sats are 99 and 100.
All right. Yeah, because the drape is too high. Not the front though, you can't? Through the front, the chest?
She's in the prone position.
Not as reliable. Okay. We're close. We're going to make a separate incision here. All right.
But we always check in the capacity too.
No, I'm glad you do. Just about done, folks. So if you have questions, type them up. I'll be happy to answer them for you. Great job, Luis, today in general. I'll answer your questions for you. But so far, everything that we're doing is happening well for her. Just need to get down to the sacrum for this last week. It's really a burn, by the way. Too low. We're actually burning the pain nerves. Shot. Too low. Shot. Too medial. Shot. It's almost good. Shot. That feels better. Nope. Still not good enough. Shot. Too medial. Hey, watch the scope there. Shot. All right, let's see. Shot. Nope, too medial. Shot. Shot. That's really nice, actually. So the reason we came up with this treatment is we saw our patients were getting better with the RFA, but it wasn't lasting. Shot. And when I started to talk to Dr. Patel, I asked him, why doesn't it last? And he said, well, just the nerve grows back. And then I realized, well, there's a way to do this without the nerve growing back. But it requires a different treatment, different way of doing it. And that's why we started doing. Everything okay?
Yeah, we're just checking them last.
Shot. The DPR. How are we doing?
I'm fine.
We're done, I think. Shot. Let's just get one more picture. Shot. Okay? A lot of arthritis here. All right, we're done. Great job, everyone. We completed the Deuk plasma rhizotomy. It's not an RFA, but it's a rhizotomy. That's what the RFA is supposed to do, is a rhizotomy, but it doesn't work. And that's why people keep coming back for RFAs. But this should be a permanent fix. And then we did the thoracic DLDR up here. Everything looks good. We're going to put a little steri-strip and a Band-Aid, and we're done. There's no stitches needed for this. All right. Thanks, everybody. Good work. Let's type your questions up for me, and I'll answer them face to face with you. By the way, the first patient who we did today, he was a 6-level lumbar. He left with no pain in his back or legs, gone. And we'll see him tomorrow. Hopefully we'll be able to do a nice little video testimonial. Our second patient, which was the L5-S1 with the degenerated disc, we did the DLDR. He had no more of that pain he had before surgery was gone. He's gone as well. So this is our third and last patient of the day. And I've got my fingers crossed for her. So God willing, she'll do fantastic. Type your questions up. I'll come answer them for you. Thanks for joining us. You want to go to a thoracic testimonial? Hello, I'm Dr. Ara Jigmejian at the Deuk Spine Institute, and I'm here with one of my patients who's just came in for a checkup today, and she had the Deuk plasma rhizotomy. This is a new type of rhizotomy being done to treat facet joint pain. I say it a lot, but the most common cause of back pain and neck pain is a herniated disc. The second most common cause is a arthritic facet joint that's painful. And the standard treatment these days is something called a radiofrequency ablation, or RFA rhizotomy. The problem is that RFA rhizotomies don't deliver very much energy to the facet joint. So if they get the nerve, usually it's temporary and the nerve just grows back. We figured out a way to deliver more energy through what's called a plasma rhizotomy. It's a Deuk plasma rhizotomy, and you had it done about a week ago. How do you feel today?
Amazing.
Yeah?
I have zero pain. So
And what did you say to me earlier? This is the first time you've been pain-free in
years.
years. How many years have you been dealing with back pain?
Yeah, probably 10.
10 years.
It's been a long time.
And
yes.
you look very happy.
I'm very happy.
Now, you did have the RFA. It worked for, gave you some relief for a little while, then the pain came back. And this feels different though.
This feels different, as in within 2 days I had zero pain.
It's awesome.
And now here I am a week later. I can run a marathon, I think.
Good.
I
Well,
mean,
we
I
want you
won't
to.
yet, but I can, so.
All right, and there's millions of people out there, and that's why we do these testimonials, really for them, not for me, not for you, but it's to spread the message of hope that there is a way to get out of back pain. You just have to stick with it, find the right place, get the right procedure, and eventually you can get there. And what do you say to that?
I say you're correct. That's Deuk Spine Institute didn't give up on me. I've had several procedures, but you kept pursuing my pain until you figured it out. So thank you very much.
You're welcome. My pleasure. Anything else you want to say to your fans out there?
To my fans, come see this man. He is amazing. Deuk Spine Institute staff is amazing. Everyone treats you with respect, and they listen to you. That's very important to me. So I just want to encourage people, don't live with the pain. Please come see Dr. Deuk and Dr. Patel at the Deuk Spine Institute.
I appreciate you saying that. The lesson here is don't give up on your pain.
Yes.
There is a way to fix it. And a lot of patients, probably about 25%, end up having more than one source of back pain. And we have to treat each source because each source requires a slightly different treatment. The rhizotomies definitely were what you needed, but you needed a rhizotomy that worked well because of all the inflammation of the facet joints and the scar tissue. And the plasma rhizotomy is the most powerful rhizotomy that can be done. It's only done at Deuk Spine Institute. So congratulations on your new lease on your back. All right, let's get you out of here. Okay, hopefully you enjoyed hearing from one of our patients who had the Deuk laser disc repair, and we fixed the pain in her back. This patient we've just completed. She has had thoracic pain in her thoracic spine, right in the center between the shoulder blades, like many people does, and she was unable to get fixed anywhere else. She found our Deuk laser disc repair, came here. We looked at her MRI. She's got, you know, literally a bunch of little disc bulging here and there, but two of them really stood out. The number T5-6 and T7-8. So when we asked her, all right, where's your pain? She pointed in that area. And today, before surgery, I actually marked out where her pain is, and we put some X's where the most pain was. And I think we got that area with the bottom disc, but the upper disc, very strange. There's some kind of weird anomaly that she has with her transverse processes. These are called transverse processes. They're bones that project off the spine sideways, and she had some kind of weird kind of connection between these two, which makes it impossible for me to get into the disc from the transforaminal approach, because these bones were fused together rather than being a gap. So I was hitting the bone. I tried changing all my planes at T5-6 to get in, and I couldn't get past this weird bony connection that was there. And I think it's just the way she was born. That said, when I asked her during surgery, do you have pain up here at T5-6? She said, no, I don't really have minimal pain there. So we're going to see how she does, but we fixed one of the two discs, 7-8, and the thoracic, and it went very well. She clearly had a big tear there. It was a lot of blue stuff. It stuck in the tear. We cleaned it all out. I feel good about that. And then we went down and we did our Deuk plasma rhizotomy. Now, people ask me about the Deuk plasma rhizotomy. What are we doing here? Some people have pain in their facet joints. That's a facet joint right there, folks. Watch. See it move? These joints move. And when you injure the joint, you can get pain in the joint. So the nerve to that joint runs right along, right here. It comes out the foramen and runs right along the bone. And if you burn the hell out of that nerve, you deaden it right there, then that joint won't feel pain, and the pain goes away. You got to do it in both places, though. If that's the joint, you got to do it above and below. All right? So we did that burning. That's what it looks like, the red area. This is what an RFA does, just to give you an idea. You guys see that dot right there?
Yeah.
So that's an RFA. That's why they don't work. And that's the Deuk plasma rhizotomy. That's why it does work. It's far more effective. And we've never had a patient come back after the DPR with facet pain at all. Now they come back, they may have facet pain above where we treated or below where we treated, but where we treat, we've not had anybody come back at where we treat. Okay, let's take our questions.
First one comes from Chris once more on YouTube.
Hello, Chris.
They asked, does the DLDR compromise the structural integrity of the disc in any way?
Yeah, we get this question quite a bit. Does the DLDR compromise the structural integrity of the disc in any way? The answer is no. Here's why. All right, let me see if I can show you. Can you guys see this little thing?
Yes.
Okay. So this is a disc, all right? And the wall of the disc is fine except where there's a tear in the back and the herniation is sticking in the tear right there. You guys see that?
Yeah.
So what we do with the DLDR is we actually come in right through the herniation and the tear. So this area is damaged already. We're not going through a normal area of the disc to fix this like this. We're going through the damaged area all the way in, and then we're pulling out. As we've come out, we zap and clean up the herniation. So the answer is no, we're not damaging in any way the disc. It's already damaged. If the disc wasn't damaged, we wouldn't be operating. And we're just happen to be going in right where the damage is. That's what the brilliance and beauty of the Deuk laser disc repair is. We're not creating any new damage at all. We're going through the damaged area, which if this is the size of the hole we make with the Deuk laser disc repair stuff, this is the size of the damage. So the damaged area is bigger than the tube that we put in there. And by the time we're done, we remove all that junk out of there, the hole is closed up to about 3 millimeters typically. So the Deuk laser disc repair actually helps the hole heal by closing it up, taking it from a 7 or 8 millimeter hole down to a 3 millimeter hole by cleaning all the junk out from the center of the hole. So the Deuk laser disc repair actually improves the disc by shrinking up that hole where the annular tear is.
Next question comes from XC once more on YouTube.
Hi, XE.
asking.
Did you like how we wrote your name? Yes, you're asking questions live. During surgery, I'm answering them live.
Yes. Have you attempted to implement this procedure as standard surgical option in any hospital or health systems?
Have I attempted to implement this surgery as a standard treatment in any hospital or health systems? Yes, it is standard treatment at Deuk Spine Institute. We have our own hospital here. It's not a real hospital with hundreds of beds, but it's a surgery center licensed in the state of Florida as a surgery center, ambulatory surgery center, and it's standard here at the Deuk Spine Institute. Is it in your Kaiser Permanente hospital? No, it's not. Is it in the Mayo Clinic? No, it's not. Why? Because it was discovered and pioneered here at Deuk Spine, and there's a lot of reasons why doctors don't do it. One of them is they don't know about it. That's most of them. Second reason is the doctors are very happy making a lot more money doing more invasive surgeries on you, patients, where they make up to 10 or 20 times as much money as I make doing an endoscopic surgery. My typical endoscopic payment is about $1,000 for my work as a surgeon, and if I did a fusion, on the other hand, I'll make anywhere between $10,000 and $20,000. And a lot of surgeons charge a lot more than me. They can make $40,000 or $50,000. So surgeons don't want to say not make $50,000 and make $1,000 instead. They are more focused on the bigger paying surgeries, which is your artificial disc, your fusions, your laminectomy and discectomy. Laminectomy and discectomy pay the surgeon about $2,000 or $3,000, and the difference though is that when you do a laminectomy on a patient or a discectomy, you know that by tearing up the back of the spine doing the surgery, you're going to bring that patient back again in a year for another surgery, like a fusion. So it actually pays you more when you do a laminectomy, discectomy, because you're going to get the fusion down the road. And then once you get the fusion, you're making 25 to 50,000. Then you're doing another fusion a few years later because of adjacent segment disease. So doctors on average will collect anywhere between 20 to 100,000 on per patient with a back problem, because they're doing multiple surgeries on you, and they keep bringing you back for more treatment. So there's a lot of money to be made. Whereas if you do the Deuk laser disc repair, you're getting $1,000 and that's it, because the patient's done. They don't come back, and they're doing great, and you're basically out of all that extra money. So surgeons don't want that. They want the money. They want you to have more invasive surgeries, and that's why there's so much fusions out there, and artificial discs, and laminectomies, and discectomies. Great question. Thanks for asking.
These next two come from Chris once more on YouTube. First question is, do osteophytes in the vertebrae impact the success of this procedure or diminish a patient's candidacy for this procedure, DLDR?
Great question. So we get this a lot. The osteophytes, which are bone spurs, do they in any way impact the success of the surgery? No, they don't. Not at all. Never have. Never will. And are patients with the osteophytes still candidates? Yes, you are. Absolutely. If there is an osteophyte, and by the way, there was one in this patient, a small one, and I zapped it away with the laser. If you go back and watch it, it was on the left-hand side. It was like a little bony bridge. Long story short, doesn't matter if there's osteophytes, the surgery still does the job.
And then last question from Chris asking, do you have any procedures to remove vertebral osteophytes?
Do I have any recommendations for procedure?
No, do you have any procedures to remove vertebral osteophytes?
Yeah. So Chris, once again, the laser that you just saw removes osteophytes. The reason why we don't remove more osteophytes is it's not necessary to remove osteophytes. What can I make an analogy to? Let's say your battery on your car dies, and you go to start the car and it's not starting. So all you need to do is charge the battery or replace it, one or the other, but you got to deal with the battery. if you lift your trunk, or your hood of your car, and you look in the engine compartment, and you see that there's some rust on the casing of the engine on the outside, but you know, the rust isn't doing anything. Why would you take your whole engine out and put a new engine in? That's what the bone spurs are in the spine. They are the rust on the engine cover. It doesn't affect performance at all. Just a little bit of rust there. You don't need to treat it. But you see what these surgeons do is they'll take a patient like you, they'll lift up the hood, and they say, look at that rust on your engine. That engine needs to be removed and replaced. In other words, you need a fusion. You need a laminectomy. You need a discectomy. You need drilling and right? And then you guys eat it up like it's real. But in the end, they're just showing you a little bit of rust on the cover of your engine. Has nothing to do with your problems you're having. And we're going to fix the problem, which is just charge the battery and you're off. Okay? That's the reality. And honestly, I spend 90% of my time answering questions that are based on misinformation. In other words, doctors, books, nurses, chiropractors, therapists misinform people, and they tell them, oh, you got bone spurs, oh, you got an annular tear, let's do some chiropractic treatment for 3 months and the pain should go away and the disc will heal. No, they don't heal. And the pain will go away, but it's going to go away on its own. But it's going to come back as soon as you get active again. That's because you never fixed the problem. So I spend a lot of my time dispelling myths and untruths, and bone spurs are one of those. You don't need your bone spurs removed, period. They don't cause problems.
That is it.
All right, well, I hope you enjoyed the surgery. This was a special case. Our patient traveled all the way from North Carolina because she's been suffering with thoracic pain and lower back pain for a long time. And we addressed both problems with kind of two different separate procedures, one being the DLDR for the tear at T7-T8, and the other one being the facets that were arthritic in her lower back. She got the rhizotomy done for that. And we'll see tomorrow how she's doing. Other than that, have a great evening. I'm glad you were here to watch our surgeries, and we'll be back Thursday with 4 surgeries. And next week on Tuesday, we'll be doing a lumbar fusion, old-fashioned way. This will be a single incision in the back. I'm going to be taking out all the bones and ligaments. Henry's going to capture it all on video, and we're going to put that on our new website so that people can see what a fusion really does. It destroys the back of your spine to get the bones to fuse together. And it's totally unnecessary when you're doing laser surgery. Have a nice